ready?
Yep, it's on. You're ready to go.
Okay. You want to... So Libby, Lisa, Brandy, you're here? Where's Brandy? Yeah. So I'm going to show the cases, and it's going to be more like question and answer. Make it a little bit more fun. So here's the case. The medical director of your facility received the following urine antibiogram. Can you hear me? And she was wondering how she should interpret the result and if any actions are needed. So I don't know if you can see this, but the Cipro for E. coli is 62% sensitive. For levofloxacin is 50. So the question, you have to decide, this is the antibiogram. This is the starting point. And then the question is, so how should you react when you see that antibiogram? Go for it. So it's your. So what are you going to do?
Cefazolin.
76% for cefazolin. So what are you going to do for that facility? It's not one patient. It's your whole antibiogram. Yes?
So you probably want to look at their care path or their policies and see that if they have a flow of selection, what is the first line?
Right. So you have to figure out if they have guidelines.
Mm-hmm.
What else?
Those include the agents that are most effective for them.
Do you want to know what they use for their UTI?
Yes.
How would you do that? Huh? Examine what's in the toolbox. That's exactly right. What else? Let's see what the next question is. So you're concerned about the resistance of E. coli to ciprofloxacin, and you decide to investigate the use pattern of this antibiotic. So you have to see, are they using Cipro a lot, and that's why the resistance is there, or you're getting a lot of patients from the hospital where they use too much Cipro. And so this is data that is from one of our nursing home. And maybe, so you could see that UTI is the most common reason for antibiotics. So you need more information, right? So you want to see what do they use for UTI. And guess what? What do you think the percentage of UTI treated with Cipro is? 90%? So here it is. Oh, yeah, it's almost there, right? So Cipro is #1 reason for it. So what would you do? So you have that antibiogram, and you show this data. So what would you do, right? What would you do next? You check the toolbox, the emergency box, and then so what should you do next? Check if your facility has guidelines for UTI treatment, and if they need to be updated. Check the emergency drug box to see what antibiotics are available. Perform a chart review to assess the best approach for an intervention, and or all the above. All the above. All the above.
Can I actually add in, there's another thing that I think we should do before we start doing chart review, which is go talk to some of the providers with the antibiogram and say, your susceptibilities for this drug you're using all the time are less than 70%. So this, I don't know that this projects, but this should not really, this is a drug that the pathogen is not susceptible to. It's what we're using primarily, so let's talk about this. And I guarantee you in this case, the providers will say, but it works. But it's probably working because they're treating asymptomatic bacteria. So that you have to, before you can go do your chart review, you have to figure out what your question is. And that's what we learned in these nursing homes, is it wasn't how are they treating UTI, it's what is their perception around it. And it was they're actually not treating UTI, they're giving antibiotics inappropriately.
That's why it worked.
So that refined the data we wanted to capture. It wasn't just about organism and susceptibility. We had to be sure we went back far enough to be sure we were getting symptoms so that we could provide that data back. So before you ever pick up an audit tool and go audit antibiotic use, talk to the providers, because they will tell you the most amazing things. They'll say, oh, it works all the time. And you scratch your head and you're like, why does that work if it's resistant? and I know that sometimes antibiotics will treat an organism even if it has a high MIC. But the reality is it'll be very forthcoming. They'll just volunteer the data that says this is not working.
Just showing them the antibiogram, just showing them that the first doctors respond to numbers. I mean, so you're showing them how bad it is for empiric therapy. So I think that, like, when we worked with Loretto, that was our first step. We, I have to come all the way over here. They can hear me. Just like my mother. Okay. All right. So when we worked with Loretto, one of our first things that we did a lot of education, but one of the first things we did was just give them the urine antibiogram. And I know the medical director was like, really? And just showing that, emailing it out to the different providers, I think that had the biggest drop in quinolone use as soon as we showed them the antibiogram. So if you haven't done that yet, I think that is a great first step, because I think you'll see a big response, because it's a number, it's a hard, fast number, and it's low. I mean, it's 50%.
So, Brandy, what did you do?
So what I started to do, and it was just on one unit at a nursing home that I picked, I was gathering a bunch of information on a spreadsheet and finding that many antibiotics were inappropriately prescribed. They were treating for asymptomatic bacteria. I didn't attack that yet, but what I did write up was the amount of Cipro that was being used and the susceptibilities. So what I was finding a lot when I was looking at these cultures was several of the UTIs were susceptible to Macrobid or Bactrim, and there were no contraindications for use. Their creatinine clearance was fine. There was no sulfa allergy. So I started to write up a little FYI to the doctor, nurse practitioner, whoever answers the recommendations at the nursing homes, just saying, FYI, this patient was placed on Cipro on this date for this many days for a UTI. It was susceptible to Macrobid, Bactrim. Again, you have to tailor it to the patient, a more narrow spectrum antibiotic, which is preferable to be used as opposed to the broad spectrum antibiotic, which increases the risk of antibiotic resistance and C. diff infections. So I stated all of that in a recommendation, FYI, for future antibiotic selection. And then in months following, I've found that they are using much more Macrobid and Bactrim. The usage of Cipro and fluoroquinolones has subsequently went down significantly just by stating those little FYIs to the doctors.
Libby, can you talk about what you did with when you got to the emergency box, antibiotic in the emergency box? It was important, right?
It was very important to know what they had available in the emergency box, because that's going to initiate the course, and it's unlikely that's going to be changed. So at our facilities, nitrofurantoin was never present in the emergency box. So we got it in there, but there were multiple quinolones. So we worked to decide what quinolone would really be needed in the emergency box for the initial dose that would allow different antibiotics to be dispensed the next day when the pharmacy was open again. But that was a key component and driver of all their antibiotic treatment, especially for urinary tract infections. So it was the other piece of when we changed the emergency box was educating the nurses about why we were making the change to the emergency box and how they could use those medicines. That engaging the nursing staff with us while we were making those changes was very important, because they raised concerns. Oh, is that hard for us to give? Is that, they had some very practical administration questions that working with the pharmacist and having that real-time interaction was really helpful to having success of the program. So they weren't just getting orders for drugs they weren't familiar with. We could address all their questions and what they were going to read in the drug guides ahead of time, so there weren't problems when they went to administer it.
And what we did, we need to add, is the way we started this whole initiative is we showed them their C. difficile rates. So that was kind of an outcome that we wanted to reduce, the rate of C. difficile. And we showed them that there is evidence that the overuse of quinolone is probably a driver. So at least we started by that and say, okay, how would we reduce the use of quinolone? And where do you use the quinolone? And this is what the data helps. So you could see where they're using. Do they use Moxi for pneumonia? Do you use Cipro for UTI? And then how can you change that? And we did face-to-face session where you could ask questions. We showed them their own data, which was very helpful. So, so there is more. Just stay here. So your facility you find out that your facility does not have any guideline for treatment of UTI. So by the way, we have made some guidelines. We put together guidelines, and they will be available on the website. Please modify them because your resistance might be different. But what I showed you is what we have on the guidelines. So the medication bus does not contain nitrofurantoin. And because the physician avoid this drug due to its side effect and the contraindication in resident with a creatinine less than 60, so we had to educate about the new, that the creatinine clearance could be lower, could be, dropped to maybe 40 or 30 per milliliter per minute. So you decided to review a sample of medical record to learn more about the treatment of UTI and evaluate the best option to change the prescription of ciprofloxacin. And this is what we use. We didn't use this, but I created this based on your Excel sheet. And this is kind of an idea. And I like the idea that you start by the antibiotic. So we start by the antibiotic. You put the name, you put the dose, you put the duration. And then you put if someone has a symptom according to either the Loeb or the McGeer criteria. And then are they warning sign? Because if you have someone with dementia, they won't have urinary symptoms, and you have to use some other systemic findings such as fever or leukocytosis. So we call them warning sign. And you have to see if they have pyuria and what's the culture result, and was the treatment according to the guideline, and then is there a recommendation? So this is a made up, and we probably will tweak it, but this is kind of a starting point, and as you use it, you find out that you need to modify it, and this is what Brandy found. Is your sheet looking a little bit more like this now?
It looks much more like that.
Yeah. So what we did, though, is we had a case report form of 2 pages with a lot of information to collect more symptoms. And this is kind of when we use this data collection, we looked specifically at every symptom that was present. So you could see in the red are the number of patients where delirium was the only indication for testing. So we showed this to the facility and say, look, you're testing a lot of people that had delirium, and delirium included anything with mental status change. So that was kind of a start, showing them their own data to drive the change was very important. It might not be doable long term, but it's kind of a first step to get their buy-in. This was very helpful. So the next thing is we applied the criteria, the Loeb criteria, which I showed you, which include dysuria or fever plus 1 UTI symptom and sign, or 2 UTI symptom and sign. And you could see for testing, many did not fit the criteria. And then for treatment, many more did not need to be treated. So 80%, almost 80% of the patients that were treated did not need to be treated. And then we applied also the McGeer criteria, and we found similar results. The McGeer criteria take into consideration, the culture results. Same thing for the Loeb treatment criteria. They take into consideration sign and symptom and culture results. So this is something that, to be sustainable, we did it. It took a lot of time. But to make this a little bit more sustainable, I'm working with the infection preventionist and providing the infection preventionist with a line list of urine culture. And either what they have done at one of the nursing homes, the infection preventionist started reviewing the urine culture herself. And it was a light bulb. I presented this data to them. They got interested. The nursing staff did not get very interested. And then the infection preventionist started doing her own review. And she realized many things. First of all, the infection log was useless. Many of the antibiotic starts were not on there. So that was kind of the first, light bulb. So that got her to talk. She immediately ran into the nurse educator and said, look, there's so much treatment here. There's no communication with me. There's so many people with asymptomatic bacteria are being treated. So that's kind of when you get the people in the nursing home themselves to own the data, it's like it's a change. So we did it first just to get started, but you need to get them engaged. Instead of doing every urine culture, you can get them to do a sample. And you realize very quickly that it's a common theme. You don't have to review 100, right, Brandy? You just pick one unit, and it was kind of obvious what was happening. And I had the heart attack, and some of them was like, oh no. And then documentation was very poor. So that was also another intervention. Said, maybe your patient had a UTI, but what you have in the chart does not help us to make this diagnosis. We also looked in the chart, when you go and look and see if they treated empirically or if they treated post-culture. And if they treated post-culture, see if there is any documentation of sign and symptom. And if anyone really assessed if that antibiotic is needed. And you realize that when we looked at that, almost 100% of the patients did not have any sign and symptom. So whatever was the original sign and symptom were no longer there or were not documented. So that's kind of a quality improvement where you can say whenever you're going to start an antibiotic or whenever you order the culture, you need to have that time to go and reevaluate the patient. It's more easily said than done, but this is probably what we have to strive towards, and we have to find a way to make that process possible. How do we do that? The other thing we did is when the nursing, I asked the infection preventionist the first when we started, give me everyone who was treated for UTI for 3 months, and she had 50. And then Libby got the antibiotic data, and she had 180 maybe. And I said, wait. Where are they coming from? So I immediately realized I need to go to another source. Either the people are being treated without culture or the infection preventionist is not getting all the culture. And it was very clear that the infection preventionist was not getting all the culture. So as I worked with my lab to get the antibiogram, at the same time I asked the lab to send a monthly line list of all the culture results, positive, negative. So that is kind of a process that's very useful. And it's a process where you can calculate a urine culture rate. And if you want to decrease the culturing, you could just follow that. Instead of doing big-time chart review, you could look at the number of urine culture by resident day and see that that number is going down. And that's a very easy measure if your lab can give you a line list. Or the lab can just give you a count. So some of the labs just send me the count, positive, negative. And I just, say, your culture rate is X, and you started Z, and that's very good. So the goal is probably to reduce it by 50% plus, because we know that 70% of the urine culturing was inappropriate. Anything you want guys to add? There's more questions, but go ahead.
I just think the other thing that we found a lot, getting back to that symptom documentation at the time of antibiotic initiation, is it isn't just that no symptoms were documented. We actually had several cases where it said symptoms have resolved, we'll start ciprofloxacin. So it's a little bit of a two-pronged effort, but we have lots of, we could show you the snapshots we took, Dr. Damiani took pictures of the notes. That's an important education point, because it was amazing to us how automatic it was to start those antibiotics, that they were willing to write in the chart, symptoms are resolved, patient's doing fine, let's get
But
some
culture is
antibiotics
positive.
on.
But culture is positive, and that was a driver. Okay. So that's another education and feedback. Anything, Brandy or
We actually get prescribers write asymptomatic bacteriuria, start Cipro. I mean, they actually write that for us. I mean, so it just, they know it's wrong, but they still think they have to put it.
Because they have that culture in their face. You should hide it. Okay, so the next thing is question 2. All these interventions are important. Which one should be your first intervention? Create treatment guideline for UTI. Educate resident and family member on when urine should be tested and when it is important to avoid antibiotic when not needed. Educate nursing on when to test the urine, especially in resident with dementia. Educate medical staff on what to use empirically for the treatment of UTI. Present data on UTI and antibiotic use at the monthly quality meeting. So all of them are important, but where should you start? And I get that idea from Brandy. So 1, 2, 3, 4, 5. Which one do you think was the most important thing to start with? 4. 4, which is educate medical staff. It's important. 5 is to present UTI data and antibiotic use at the monthly quality meeting. Number 3. I was looking for number 3 because I talked to Brandy. Brandy, tell me what you told me. And you said, we need something very simple.
Yes. So what I'm finding is, I gathered all this information, I brought it to QA, and what I'm discovering is that a lot of the nursing staff, they may have a policy and procedure for when to order a UA, but no one knows what it is. If they, they're not following the policy and procedure. So what needs to be done is just education to the nursing staff, because they're first line. They're seeing the patient, they're seeing the symptoms, they're reporting to the doctor. So we just really I feel like we need a quick reference for the nursing staff to look at and be like, okay, this patient has this, and this symptom. Let's report this to the doctor. Maybe just like a quick reference available to them at the nursing station. I feel like would be beneficial.
So there is some tool are you familiar with the Interact? Interact, they have tool for assessment of residents with different signs and symptoms. And Interact tool includes something simple where it says, what are the symptoms that should trigger and when should you call the physician. So that's another tool you could use. We created this poster for our facilities, but Brandy thinks it needs to be very simple. It needs to be only that box in here, right? Just the one of the box. So we'll modify it.
The more simple, the better, the more likely they are to follow it. Does everyone?
Yeah.
In general.
So we're going to tweak this to make it more what Brandy wants. So the next thing is, here's another process too. So once you have the data, how do you report it? And this is not mine. This is from one of the nursing home director. And what she did is she every month I meet with her and she feeds back this data to me. Because she doesn't want me to get her data at all. She wants to be in charge of her data. So every time I meet, she gives me a list with an updated month data. So the number of urine culture per month. And she looks at the number of antibiotic start for UTI or overall antibiotic. And then she looks, she show me the rate of culturing, so you could see the rate is going down. The rate of antibiotic start for UTI is going down. And we also link into another outcome measure, which is C. diff. So that's kind of something, you guys, it's very easy to do because the data is there. The urine culture, if you can get it, is there. And so that's very simple measure to follow. Anything to add, Libby? Anyone wants to add anything? Okay. So this is kind of what I feel. I feel I cannot tell them what they should do. They come to me with what they want to do once they see the data. And this is one of the nursing home director, the way she wanted it reported. And so case 2, you are working with a medical director on your facility on initiating an antimicrobial stewardship program. Your facility had many cases of C. difficile infection over the past few months, and you would like to evaluate if antibiotics with known high risks for C. diff are commonly used. You generate a summary of your antibiotic dispensing data, and you see the following result. And maybe Libby, you can take over, because you know this case well.
Yes, so there are not comparative data to other facilities, but you know that you have a lot of C. difficile, and so you look for the normal suspects. We see some spikes around moxifloxacin, but interestingly, there is a huge spike around the use of clindamycin. Does anybody have any thoughts about this or where you might want to look? From somebody who doesn't know the answer. There are people here who know the answer to what we found. Does anybody have any unique ideas about what this might? What are your thoughts? So you see this huge spike of clindamycin. What are you thinking might be the problem? Yeah, you're good. You're good. You know this dentist. So we talked about it, and we thought it was skin and soft tissue infection. That's what we thought it was. If we had money to put on these things, this is what we would have bet. And we were wrong. You would have been right. It actually was dental prophylaxis.
So this is a case.
And I don't know if you want to go through the individual case.
But this is a true case.
Yeah.
That's why I wanted to present it. And it's kind of upsetting because, and that's why we're highlighting kind of why our role is important. So this is a 75-year-old female who had the right hip replacement on March 2015, and she was discharged to a nursing home for rehab post the procedure. Her past medical history is positive for gastric reflux disease, osteoarthritis, high cholesterol, and hypertension. She's on omeprazole. Where is he? Levothyroxine, simvastatin, lisinopril, hydrochlorothiazide. And so on August 25, she received 1 dose of Clinda for prophylaxis against prosthetic joint infection prior to her teeth cleaning, because I think she's allergic to penicillin. And on September 15, she develops diarrhea and stool test is positive for C. diff. And of note, her roommate had C. diff diarrhea and was moved out of the room few weeks earlier. So there was an exposure. She got only 1 dose of the clindamycin. And what happened, she had 4 recurrences of C. diff, and now she's being evaluated for a fecal transplant. So this is kind of an extreme case of, did she really, so the question, is dental prophylaxis is for dental cleaning needed for patient with prosthetic joint infection? And the question is yes, no, maybe. And maybe I'll let Libby take over. So the question is, what's the answer? No, you guys are good. We didn't know that. Did we?
I think that this is a common question that comes up. And when we sat down, one of our facilities that we work with and help, they have a lot of trainees that rotate there. And we had the opportunity to sit with a room full of the trainees one day. And they were like, we could ask this question all the time, and we don't know how to answer it. Interestingly, and I'll tell you, my husband works in primary care, and he gets this question all the time from the dentists. And he says, but they're your guidelines. The American Dental Association has come out with guidelines. So you know that these guidelines exist, but I think this is where it becomes a challenge, is how do we implement this in your facility? So who has an idea? So we know that the guidelines say they don't need to have the prophylaxis. How would you implement that in your facility? What do you think is the best strategy, knowing that there is no one-size-fits-all?
So the guidelines are...
I think there are different strategies that you could apply. So in a typical acute care hospital, we would try to intervene when we saw these orders coming across. But what we see in the nursing home is these are long-term standing orders. So because of that, that may be an intervention, is to go through and see who has the standing orders and then try to talk to the providers. You also obviously have to get buy-in from the dentists. And people always take these messages best from their own colleagues in their field. So these are cases where you may need to go out and get other dental colleagues to assist if there's somebody who feels that this is strongly needed routinely for these patients.
And we have to get ortho surgeons on board. I think you cannot just do it on one end without the other. We just have to get everyone and have like a position statement, which we're planning to do for our community, to have a position statement saying we no longer recommend dental prophylaxis for people who have joint replacement because of lack of evidence.
Yeah, and that's a great suggestion for your group. Is we have found a lot of power, and I say this somewhat jokingly, but it's absolutely true. So when we have our acute care hospital collaborative, it's the stewardship pharmacists and physicians from each of the facilities sitting in a room together. Nothing changes about us. We're the same people. Then we might go back to our sites and say, this is what we need to do. We want to be quinolone sparing. We don't want to overtreat the urine. Whatever it is we want to say, when we say it alone, and it's just us who've appeared to have come up with the idea, we don't get a lot of traction. But when we come back with a paper that says this citywide collaborative, which is just us, says we shouldn't do this, they're like, oh, and they can post it and they can do something. So working together with your colleagues here in this room, that's a great way to implement stewardship interventions that gets a lot more traction. If you all get together and we all say, we don't think you should do clindamycin prophylaxis based on these consensus guidelines from other professions, that's at least a way to start the conversation back at your facility. To say, this is our group has come out and decided together, this is what we want to say, and then you can take it forward.
I have more cases, but they're routine. What would you use? I think we should probably have more discussion. But we figured out something. Like we are the academic center. We're the expertise. We went there. They loved us. They hugged us. But we wanted to kind of make them sail because we cannot be there all the time. So what we figured out, we needed to get, first of all, the medical director to buy in from the beginning. So when we did the presentation at the beginning, the medical director, the nursing director, the administrator, who was all there? Even environmental service were there because we're focusing on C. diff. We had everyone in the room. And the medical director said, this is a priority, and we're going to do what they have to say. And so that was really very important. And then with the infection preventionists, we wanted them to be more of the people doing the data, because that's what they do day in, day out. But change the way they collect the data and make it actionable. For pharmacy that were in-house, we asked them to provide the pharmacy data to the infection preventionist data. And that's kind of, the infection prevention is kind of looking at the data on a regular basis. I don't know if, John, you want to add anything. But she said, now I can look at the data and I can see who is started on an antibiotic. So it enhanced my infection log, which was really not very good. And so, and she said to me, which is very important, we used to do our work alone in silos, and now we're all together. We have a team. We're all doing the same thing we have done before, but now we come together and do it together, and it makes a big difference. And we show the data. It's part of the quality improvement data. So that's irregular feedback is very important. So I just want to highlight how important to create the team. And I did not push for it. It became, you know, it just developed. And that's what I wanted to share with you. John, or do you want to add anything?
I think a lot of nursing homes were just kind of focused on all the quality measures from CMS to form interdisciplinary teams to try to improve our numbers, especially in New York State, since we're going to like a Medicaid managed care, financial implications of facilities to how those numbers. So I think a lot of facilities are going to be going to more and more of an interdisciplinary type of fix to a lot of these problems.
Does anyone want to add anything? No?
Exactly what I think.
No? So this is all I have to say, I guess, today. And so we can open it for questions and, you know, what are some of the things you want us to answer? I think, is there anything else we learned? We're still learning a lot.
I think the most important thing to say is thank you, everyone, for coming and listening to this today. For those of you who are helping us in our collaborative, thank you so much. You know, I can't tell you how many people said the antibiotic data couldn't be done. So many things we tried, we were told this can't be done. And we've had a lot of successes because of collaborations. And I think it's great to have you all here today together. So continue to collaborate. There are lots of great, and we can't wait to see where you all go with this, because this is just going to be a fantastic time that's really exciting, and you're really out ahead, and you get to craft what this is going to look like. So be innovative and creative, and share your ideas with each other. It's fun.
Sharing the idea would be great, because, you know, we learn from others, and we would like to learn from you. Yes?
Dr. Damiani, Kelly, our president, couldn't be here today, but she asked me to thank you for sharing your grant with us and for leading the steering panel and bringing us excellent speakers today. One of our objectives was for our members to be able to go back to their facilities and implement a stewardship program, and I think you gave us, along with your speakers, enough information to be able to do that.
Thank you. I am so glad we could put this presentation together and invite all the speakers in such a short time. We had the grant that ends in March, so so we had a deadline. So thank you so much.
And secondly, we'd like to thank Brandy for not only participating in the steering group, but Brandy did all the logistics for today, got the place, did all the registrations, got all the handouts in the right place. So thank you very much. Thank you.
Did someone else have a question? Any other questions? You have my email at all? No? Maybe? Yeah, you could post it and our website. And if you have any questions and want to run ideas or figure out something that's really important that would help, just don't be afraid to send me an email. I check my emails at 3 a.m., so. Anything else? I want to highlight one.